Good evening and welcome to each one of you to the webinar on case-based approach to cardiac anatomy and congenital heart disease from the side of IRIA Kerala. And last Wednesday, actually, we saw effective case presentation done by the residents of Sanjay Gandhi Institute of Postgraduate Institute of Medical Science, Lucknow, and that was moderated by Dr. Neeraj Jain. And today, he is going to give us a talk on case-based approach to cardiac anatomy and congenital heart disease. So I welcome you, Dr. Neeraj Jain, on behalf of IRIA Kerala.
Thank you, sir.
And then Dr. Gomati Subramaniam, President IRIA Kerala, Dr. Ramesh Pisharide, Program Coordinator, and Dr. Anish Sonal, Coordinator. And actually, I welcome all of you who are all make this program functional. And I also welcome the Mindray team, who is actually giving us the platform to perform this event. I welcome you, sir. And now over to Dr. Gomati Subramaniam, President IRIA Kerala, for giving us opening remarks. Over to Madam.
Okay. Thank you, Dr. Venu, our academic chairman. I'm very happy that we are having the Mindray team as a platform for academic sessions. We have finished our chest last month and we are continuing with cardiac sessions, which is the neglected field for the residents. And today we have our Dr. Neeraj, who's going to present on the cardiac, which will be very much useful for our residents. And the residents should be very much careful in hearing it because nobody reads that chapter in our Sutton or web or any other book. Because once we hear it, it will be in our brain. So please be attentive because it will be very useful and all the cases are kept for spotters rather than kept for long cases or short cases. So thank you everyone. All the residents, please be on the line till the end of the session. Thank you. Over to you, to Mindray, to the platform for the new machine to say. I mean, your full new machine to be shown in this platform to all the residents and the faculties. Thank you.
Thank you, ma'am. Good evening, all. Myself, Manoj from Mindray. I take care of Kerala operations. First of all, we thank you very much for the opportunity by the IRA as a part of the continuous learning process. In this series, this is third session. First session, we introduce our flagship model, premium color Doppler, Resona I9. And last session, that means second session, we introduce our high-end color Doppler DC80 X Insight series. This week, we would like to introduce one more exciting product from X Insight series that's called DC70 X Insight. It always a question comes to us by the customer, what do you mean by X Insight? It's nothing but we collected a lot of pain points from you doctors, from the customers across the world. With our insight, we designed this product. For example, normally in conventional ultrasound, we used to find only one processor, CPU, control processing unit. But we are here offer thunder speed engine. That means GPU and CPU architecture. With this, we can improve the image processing speed 3 to 4 times faster. This model offer you single crystal convex probe and the combo wave linear transducer for excellent image performance. As we know, IRA is taking a lot of initiative towards preventive radiology, and we are proud to associate IRA for the preventive radiology program, especially on elastography. DC70 X Insight supports shear wave elastography. What important is we build with some quality factors like reliability index and motion index. Reliability index is visually ensure receiving the data at minimum 85% level and above for the accuracy. Motion stability index visually confirm you that there is no patient breathing. And if you take ROI, region of interest, normally all other vendors, you cannot adjust region of interest. But our series, we can increase and decrease ROI box. And you can acquire multiple values without cooling time. That's why we call.
Manoj, sorry, are you sharing screen?
No. Also, DC-70 action site powered by artificial intelligence, especially on fetal imaging. This help you to improve workflow. And our sincere thanks to Dr. Gomati, Honorable President Kerala IRIA, and Dr. Rijo Matthew, Honorable Secretary Kerala IRIA, and Dr. Venugopal, Academic Chairman, Dr. Ramesh Jain, Program Coordinator, and all other zonal coordinators for this wonderful opportunity. And wish you all the best, Dr. Neeraj, for your section. And my colleague Karthikeyan will be playing a short video. Over to you, Karthikeyan.
No sound, Karthikeyan, no sound. Karthikeyan, can you hear us? That we cannot hear any sound. Please select Manoj. You will have to call him. I think so. Karthikeyan, you have not selected the volume button at the bottom.
I think we have some technical issue. I guess.
Yeah. It was wonderful.
Thank you, doctors.
Over to you, Dr. Anish, to introduce Dr. Neeraj.
Okay, ma'am. I'm Dr. Anish, Zonal Coordinator for IRIA PG Training Program 2022. It's my honor to introduce Dr. Neeraj Jain, who is giving a talk on cardiac CT. It's a case-based approach on cardiac anatomy and malformations. Dr. Neeraj is working as associate professor in Sanjay Gandhi Postgraduate Institute, Lucknow, which is one of the top institutes in our country, where all the advanced imaging and interventions are being done. Even I had the privilege of working there for 2 years in 2011 to 12 that time. So they have a lot good collection of cases. Some of the cases we have seen in the Wednesday's PG presentation. So here, Dr. Neeraj is working as associate professor now. He is working as started as assistant professor there in 2017. He is very academic oriented. He has more than 50 publications in national and international journals, and more than 25 poster and paper presentations in conferences, nationally, internationally, Karasane, etc. So now I invite Dr. Neeraj for talk. Over to you, Dr. Neeraj.
Thank you, Dr. Anish. At the outset, I would like to thank Kerala chapter of IRA for giving me this opportunity to speak on this topic, and the sponsor, Mindray. So I'm going to share my screen. Is my screen visible, clearly visible to all?
Yes, it's clearly visible.
Yes.
Yeah. So good evening to all. So
Can you slide share it?
Yes.
Down. You can go down to your slide share. Can enlarge.
Yeah, it's on the full screen.
No, it's not full screen. Yeah, now it's okay.
Yeah. So in next 30 to 40 minutes, I'm going to discuss a systematic approach to the congenital heart disease with relevant anatomy. So whenever a patient comes for the evaluation of the congenital heart disease, the one thing we need to be sure or certain is the indication. Because majority of the time they want to, the cardiologist or the cardiac surgeon, they want to answer to a very particular or a specific questions, like they want to know the size of the pulmonary artery. And as majority of the patients are the small kids, we need to plan or we need to tailor our study accordingly, because it's a very fast study. CT is especially very fast study. You may miss a contrast in the right sided chambers, and if you wanted to see the right side of the heart, so you need to be very meticulous in your planning. So the most popular system which describes the congenital heart disease is a von Prague classification system. It involves 3 steps. In the step 1 involves the determination of visceral situs, thoracoabdominal situs, and atrial situs. Step 2, we determine the ventricular loop, and step 3, the position and the relationship with the great vessels is determined. But if you stick to these 3 steps, there are chances that you may miss certain important findings which may be of critical importance to the cardiologist or the cardiac surgeon. So I have added some addition. So there are some additional steps in addition to these 3 steps, which we follow, and I expect you to follow also. That is the identification of the atria and ventricles, determination of the relationship between the atria and ventricles, the ventricles and the great arteries, and other connections such as pulmonary veins, inferior vena cava, superior vena cava, and the various septal defects. So before I come to the actual approach, there are certain rules which you need to remember here. Be careful to use word right or left whenever you describe the cardiac chambers, because there are chances that right atrium may be situated on the left side of the body, or the left atrium may be situated on the right side of the body. So always use a word morphological rather than the actual right or the left ventricle. Another thing is the dextrocardia is not synonymous with the dextroposition. Similarly, the levocardia is not synonymous with the levoposition. Dextrocardia indicate that base to apex axis of the heart is directed toward the left side, while the dextroposition is that the greater or the majority of the mass of the heart is located on the right side of the chest. Just by saying that dextrocardia and levocardia is present, it does not mean a particular internal structure of the heart. And the heart may be positioned on the right or the left side of the chest secondary to the lung abnormality like collapse. So I'm going to discuss a systematic approach which is essentially based on the von Bragg notation system with some modifications. Step 1 involves determination of the situs. The first step we see is the position of the abdominal organs. In a normal patient or in the situs solitus condition, the largest lobe of the liver is situated on the right side, and the spleen and the stomach is on the left side. When we determine this abdominal situs, the next step is to move towards the thoracoabdominal situs. So in the thoracoabdominal situs, the most important thing to be noted here is the morphology of the bronchi. The right bronchus is short. It shows the early origin or early uptake of the right upper lobe bronchus, whereas the left main bronchus is a long structure, is long in length, and it shows the distal origin of the left upper lobe bronchus. In addition to that, the right bronchus is a eparterial bronchus. It means the bronchus is situated posterior and superior to the right main pulmonary artery, whereas left main bronchus is a hyparterial bronchus, which means that left bronchus is situated inferior or caudal to the left pulmonary artery. Like in this image, you can see this left main bronchus is situated inferior to the left pulmonary artery. Otherwise, as we all know that right lung has got right lung is a trilobed structures. It shows two fissures. One is a horizontal fissure, another oblique fissure, and the left lobe is a bilobed structure which shows only one fissure, that is an oblique fissure. So why we are discussing this bronchial anatomy when we are trying to discuss the congenital heart disease? So here comes our rule number 1. The pulmonary sidedness is usually reflect the atrial sidedness, which means if you see the right-sided bronchial morphology, that is the short bronchus, early uptake of the right upper lobe bronchus, eparterial bronchus, that you can be fairly certain that right atrium is situated on the right side of the body. But there are certain exceptions, like in this, which is an isomerism. Like in this case of right isomerism, you can see this both lungs shows the early origin or the early takeoff of the upper lobe bronchus. While in cases of left isomerism, you can see both the bronchus shows the distal takeoff of the upper lobe bronchus. This is a case of left isomerism. So now we have fair idea that by looking at the bronchial anatomy, that which atria is located on the which side, but still we have to look inside the ventricles or the morphological characteristic inside the atria or the morphological characteristic of the atria to determine which is the right atria and which is the left atria. So this atria can be identified by the presence of its appendage morphology. So left atrial appendage is right atrial appendage is a broad. This is the right atrium cavity, and this is the right atrial appendage. The right atrial appendage is a broad, blunt, and it has got the broad communication with the right atrium. It is also trapezoidal in shape. So you need to remember triple B, the broad, blunt, and broad connection. On the other hand, the left atrial appendage is a narrow, tubular, and it has got relatively narrow connection with the left atrial appendage. Now we have determined the atrial morphology and locate the which atria situated on the both sides. At the same time we need to look inside the atrial chamber for any abnormal structure or intactness of the interatrial septum. Like in this case, you can see this the interatrial septum, which separates the right atrium from the left atrium, is absent. So this is a case of single atrium, and this single atrium is connected to both the right ventricle as well as the left ventricle. In another case, you can see this thin membrane-like structure is seen inside the left atrium cavity and dividing into two unequal compartments. On one compartment, all the pulmonary veins are seems to open. So this is a case of co-triatrium sinister. As we all know that deoxygenated blood returns to the heart via superior vena cava and inferior vena cava. So both superior vena cava as well as inferior vena cava opens into the right atrium, and the deoxygenated blood from the heart enters to the coronary sinus, and this coronary sinus subsequently opens into the right atrium. So all the venous returns comes to the right atrium. But there are certain instances where you may see a presence of double SBC. Like in this case, you can see there is a right SBC and the left SBC on the left side. And though it's not seen in this image, the left SBC is opens in majority of the time it opens into the coronary sinus. So here comes our second rule, which is the rule of veno-atrial concordance. The suprahepatic IVC and coronary sinus is almost always opens into the right atrium, with a few exceptions, like in cases of isomerism. In cases of left isomerism, the IVC is interrupted with azygous continuation. So now we have seen the inside the chambers. Next step is to see the venous connections to the left atrium. So all pulmonary veins, these are the pulmonary veins on the left side, pulmonary veins on the right side. So all four pulmonary veins, the right superior, right inferior, left superior, left inferiors, opens into the left atrium separately. While in this case of the total anomalous pulmonary venous connection, you can see the right superior, right inferior, and the left sided pulmonary veins join together to form a common vertical vein, which extends cranially and then arches over toward the right side and then subsequently open to the superior vena cava. The superior vena cava is dilated and it opens into the right atrium rather than opening it. So it's an anomalous venous connection. So pulmonary veins are not opening into the left atrium; they are opening into the superior vena cava, which is subsequently opens into the right atrium. So now we have established the atrial chambers and their connections. Time to move towards the ventricles. But before come to the ventricle, we need to see the status of the atrioventricular valve. The mitral valve separates the left atrium from the left ventricle, and the tricuspid valve separates the right atrium from the right ventricle. The mitral valve is the only bicuspid valve in the heart. Rest all three valves are the tricuspid valve. So the one characteristic feature of the left-sided chambers of the left atrioventricular wall is the presence of fibrous continuity between the mitral valve and the aortic valve. This is the mitral valve, and it is seen to be continuous with the aortic valve. On the other hand, this is the image showing the right atrium morphology. The right atrium has got right ventricular morphology. Right ventricle has got three parts: the inlet part, the apical trabecular part, and the outlet part. So this is the expected location of the tricuspid valve. As you can see, this muscular ridge, which is known as ventriculoinfundibular fold, separates the pulmonary valve from the tricuspid valve. So there is no fibrous continuity seen on the right side. Again, you can see in this image, there is a relatively distal, the septal leaflet or the apical leaflet of the tricuspid valve is moved caudally, and you can see the part of the left atrium, part of the right atrium is going and projecting and encroaching upon the right ventricle. So this is a case of Epstein anomaly in which there is atrialization of right ventricles happen, and there is apical displacement of the there is a displacement of the apical leaflet of the tricuspid valve. Now we have seen that atrioventricular valve. This next step is to identify and see the ventricles. So before we determine the ventricular loop, the first step is to identify which is the right atrium and which is the right ventricle and which is the left ventricle. So in this image, you can see this is the right morphological right ventricle. The right ventricle shows coarse trabeculation and presence of attachment of trabeculation. Like in this case, you can see this is the moderator vein, which is extending from the ventricular septum towards the cardiac, towards the apex. On the other hand, you can see the interventricular septum, the LV side of the interventricular septum is smooth, and there are fine trabeculation and the compact nature of the LV wall. But there is one condition in which you can get that coarse trabeculation on the left sided cavity, on the left ventricle as well. Like in this case of non-compaction, you can see the ratio of the trabeculated versus the non-trabeculated versus the compact myocardium is more than 2, definitely more than 2.3. So now we have determined and identified the ventricles. Next step is to determine the ventricular loop. By the 23 to 28 week of gestations, the cardiac tube elongates and it's folded cranially and caudally, and then it rotates toward the right side, establishing the D loop. So the looping can be determined by the relative position of the ventricles. In cases of D loop, the right morphological right ventricle is situated right to the, this is the left ventricle, the morphological right ventricle is situated right to the left ventricle, while in cases of L loop, the morphological right ventricle, which is, can be identified presence of moderator vent, is situated left of the left ventricle. Another way to determine the looping is by the loop rule. So here comes our third rule of this is a loop rule. So position of the great vessel can indicate looping. If the aortic valve present on the right side, it suggests the D loop. If it is on the left side, it suggests the A loop. Like in this case, you can see this is a normal patient. You can see the pulmonary artery or the pulmonary valve is situated anterior and left of the aorta, suggesting D loop. While in this case, you can see the aorta is situated left of the pulmonary artery, suggestive of L loop. So now we have determined the looping. The next step is to see which atria is connected to the which ventricle. In a normal patient, like in this patient, the right atrium is connected to the morphological right ventricle and the left atrium is connected to the morphological right ventricle. But there are certain instances where this connection may be abnormal, known as atrioventricular discordance. So in this case, you can see this looks like a morphological right ventricle, which is situated left to the morphological left ventricle. So this is a L loop kind of atrial arrangement. Here you can see this morphological left atrium is connected to the morphological right ventricle, and morphological right atrium is connected to the morphological left ventricle. So there is a atrioventricular discordance here. Now we have seen a discordance. We have to at the same stage we have to detect the presence or absence of various septal defects like the ventricular septal defect or the patent ductus arteriosus. Like in this case, you can see the part of the interventricular septum just underneath the aortic valve is missing. So this is a case of subaortic ventricular septal defect. And you can see this aorta seems to override this interventricular septum with a more than 50% override. More than 50% of the aorta, more than 50% of the diameter of the aorta is receiving blood supply from this trabeculated chamber, but looks like a morphological right ventricle. So this is a case of subaortic ventricular septal defect with double outlet right ventricle. In another case, you can see this is a long tubular-like structure is seen arising from the descending thoracic aorta, just distal to the origin of left subclavian artery, and this structure seems to connect with the left pulmonary artery. So this is a case of patent ductus arteriosus. One concept I would like to elaborate is the concept of double outlet right ventricle. So here comes our rule number 4. If one great artery and more than half of other great artery originate from morphological right ventricle, then it is known as morphological right ventricle. So this is a normal patient. You can see this is the morphological left ventricle, interventricular septum, and the right ventricle, and the aorta is completely arising from the morphological left ventricle. While in this case, you can see here is the interventricular septum. The septal side here is a smooth, so it looks like a morphological left ventricle, whereas the septal side on this side is not smooth, ensure attachment of papillary muscles or the trabeculation. And more than 50, if I draw a line from here to here, you can see this more than 50% of the aorta is arising from morphological right ventricle. So this is suggesting a double outlet right ventricle. Another, like this is the picture I have shown in the previous slide, which is also showing the double outlet right ventricle. Though it's not a diagnostic criteria, but the aortic mitral continuity is frequently lost in cases of double outlet right ventricle. Like in this case, the image I showed in the previous, there is a fibrous continuity between the aortic valve as well as the mitral valve. But here you can see this is the aortic valve, this is the mitral valve, and there is no fibrous continuity between the aortic and mitral valve. So frequent the mitral to aortic continuity is lost definite in cases of overt or very high degree of double outlet right ventricle. Now the last step comes here. Now we have seen the ventricle. Now we identify the septal defects. Now we determine the atrioventricular concordance. The next step is to determine the position and relationship of the great vessels. This relationship is determined at the level of aortic and the pulmonary valve. Sometimes what happens is the aortic root and the pulmonary artery may be grossly dilated. It may be difficult for you to determine where are the valve. In this case, you can see this relationship at the level of aortic root as well as at the level of main pulmonary artery. So one rule is need to remember here is that aorta is almost always located on the right side of the pulmonary artery in a normal patient. Like in this patient, the pulmonary artery is left and anterior to the aorta. While in this case, you can see this aorta, which can be identified by presence of coronary artery, is located anterior and left to the pulmonary artery, suggestive of levotransmission of great vessels or LTG. If the aorta is situated right and anterior to the pulmonary artery, it is suggestive of detransposition of the great vessels. So you need to see the position of aorta. The aorta had to be posterior to the pulmonary artery. It can't be anterior to the pulmonary artery. If it is anterior to the pulmonary artery, it is suggestive of transposition of great vessels. So now we have determined the position of the great vessels. The next step is to see these great vessels, are they normal? Is there stenosis or narrowing is present? Like this is a normal right ventricular outflow tract image of the right ventricular outflow tract. The right ventricular outflow tract is demarcated, is extend from the medial papillary muscles here, and it extend to involve the pulmonary valve. So this is the area which correspond to the right ventricular outflow tract. And the infundibulum is a muscular structure which supports the pulmonary valve, and it can be identified by presence of this muscular ridge, which is seen along the posterior wall of the infundibulum. This muscular ridge is known as ventriculoinfundibular fold or crista supraventricularis or supraventricular crest. We have previous slides, we have also discussed this crest help to separate the tricuspid wall from the pulmonary valve. So we need to give the several diameters here. We need to give the diameter of the infundibulum. We need to give the diameter of the ventriculo-arterial junction, the pulmonary sinus, the sinotubular junction, the diameter of the main pulmonary artery, diameter of the right pulmonary artery, at least at the 2 level, diameter of the left pulmonary artery. Similarly, we need to provide the various diameter of the aorta, like the diameter at the level of the arterioventricular junction, diameter at the level of sinus, the sinotubular junction, and mid-ascending aorta, because these diameters are of very critical importance to the treating cardiologist or the cardiothoracic surgeon. Now you can see, now we have seen the aorta in various diameters. It's time to see the various kind of stenosis. You can see, we usually see in cases of pulmonary atresia, pulmonary stenosis. Like this is the most common kind of narrowing or the stenosis we see in case of pathology of fellows, which is infundibular stenosis. You can see this infundibulum is grossly thickened and there is a marked narrowing of the right ventricular outflow tract, though the thymus side of the pulmonary artery is not that small. Maybe they are receiving blood supply from the collaterals. In another case, you can see the right pulmonary artery and left pulmonary arteries they are hyperplastic, but they are confluent. The main pulmonary artery is atretic. In this, you can see that this is the right pulmonary artery and this is the left pulmonary artery. Both pulmonary arteries are seen, but they are non-confluent. There is no union between the right and left pulmonary artery. In another case, you can see the main pulmonary artery is fairly normal in caliber, left pulmonary artery is also normal, though the right pulmonary artery is hyperplastic, but the second narrowing is seen in the peripheral part of the pulmonary artery. So this pulmonary artery diameter is very difficult to determine by the echocardiography, especially the peripheral pulmonary artery. So CT plays a very critical or important role in detecting or ruling out the peripheral pulmonary stenosis. So in the last step, do not forget to assess the lung and the abdominal organs for the various abnormality. Like in this case of Congenital syndrome, you can see the base to the apex axis is directed towards the right side, suggestive of dextrocardia. The aortic arch is also seen on the right side, but the important point to see here is this presence of bronchiectatic changes in the both lung. So this is a case of Congenital syndrome, which is characterized by the cystic bronchiectatic changes along with the dextrocardia. Another important, just to emphasize the point of seeing the abdominal organ, you can see this case of left isomerism. There are multiple spleen or spleninculi which are present on the right side of the abdomen. The stomach is also on the right side, and the largest hepatic lobe is present on the left side. So before I'm going to conclude my talk, I'm going to show you a couple of cases and try to apply this systematic approach in the evaluation. Let me.
Doctor, there is no movement on the screen.
Also, it is not audible.
I think Dr. Neeraj Jain is not with, I think it got disconnected. I hope he joins back. Yeah, I think he's joined back. Let's hope he is able to share the screen again.
Am I audible now?
Yeah, we can hear you, doctor.
Yes.
Sorry, I lost my connection. So
Okay.
I again start the screen share. So is my screen visible now?
Yes, please go ahead.
Yes,
Yeah,
yes.
okay. So we will start with the case. So this is a young lady who came to us for evaluation suspected case, though it's a diagnosis of congenital heart disease. Anyway, the CT angiography was done to see the status of the great vessels. So first step, like we have discussed, is to see the position of the abdominal organs. So you can see the largest lobe of the liver is on the right side, the stomach and the spleen is on the left side. So abdominal situs is normal. Next step we are going to see is presence of bronchial situs. So you can see here. Yeah, the right upper bronchus, this is the right main bronchus, and the right upper lobe bronchus is the early takeoff, whereas the left upper lobe bronchus shows a distal takeoff. In addition to that, you can see this left main bronchus is situated below the or inferior to the left pulmonary artery, suggestive of epiarterial bronchus. Coming back to the axial image. So now we see this right atrial morphology on the right bronchial morphology on the right side, left bronchial morphology on the left side. So we can safely presume that the ventricles must be of normal location. The right ventricle is on right atrium on the right side, left atrium on the left side. Anyway, we need to see the actual morphology. So like you see this chamber. This chamber looks like a morphological right atrium. This is the right atrial appendage. You can see this. Actually, I am hearing quite a bit of noise here. I request you all to mute yourself. So yeah. So this chamber's small step is to identify the atrium. So this is the right atrial appendage, which is broad. It has got a broad connection with the rest of the right atrium. So it looks like morphological right atrium. And this chamber, the left atrial, this chamber looks like a left atrium because it is the left atrial appendage is conical shape. It's narrow in comparison to the right atrial appendage. So we have identified that right atrium is situated on the right side, left atrium is situated on the left side. Next step is see the venous connection. You can see this, the IVC, the suprahepatic IVC, and the SBC. Here is the SBC. Both IVC and SBC are opening into this chamber. So we have learned the rule of veno concordance. Like whichever the chamber IVC opens is usually right atrium. So this looks like a right atrium. But in addition to that, you can see there is one more structure is on the left side, and this structure is running almost in the same course as that of superior vena cava. So this is a left sided SBC, and this left sided SBC, if I scroll it down, you can see this left side is opening into this dilated structure, which is nothing but a coronary sinus, and this coronary sinus is subsequently opening into the morphological right atrium. So we have established this. All the venous connections all the systemic venous connections are to the right atrium. Now we see the connections to the left atrium. You can see the right. This is the to this chamber which we have. So the venous connection to the right atrium and the left atrium are normal in this case. Now next step is to see which atria is connected to the which ventricle or the status of atrioventricular wall. So you can see here that this right atrium, but this is the little unusual case. Let me describe the ventricle. So there are one chamber is very small in size, another chamber is big in size. So if we scroll it down, you can see the interventricular septum. There are some of the trabeculation this side. So this small chambers looks like a morphological right ventricle, whereas the surface of the interventricular septum toward this chamber is smooth. So this looks like a morphological left ventricle. So this is not a normal relationship. This relationship is a though it's normal suggestive of D loop. Now it's a time to see the atrioventricular wall. So you can see in a normal patient, the right atrium should connect with the right ventricle. But in this case, you can see there is no connection between the right atrium and the right ventricle. In place, you can see this kind of fibrofatty ridge, which is separating the right ventricle from the right atrium. So where is the right atrium opening then? So you can see this right atrium. I scroll it down. So you can see this right atrium is connected to the morphological left ventricle. So if the right atrium is connected to the morphological left ventricle, where is the left ventricle then? So now
Dr. Neeraj Jain,
this is the left atrium. Yeah. Dr.
Neeraj Jain, this is Ekampram from Mindray. Many of our listeners not able to hear you well. Can you turn off your video, please?
Okay. My video is already turned on, actually.
Turned off. You should turn off your video.
Okay. Turned off. Okay. Yeah. Okay. So we have seen that the right atrium, instead of connecting to the right ventricle, is connected to the left ventricle. So you can see this left atrium is also connected to the morphological ventricle. So both the atria as well as left atria are connected morphological left ventricle, and there is no connection atria to the morphological right ventricle. So this signifies presence of double inlet left ventricle. Double inlet left ventricle is an entity where both right as well as left atria are connected via valve to the left ventricle. Now we have determined the atrioventricular to see the position of the great vessels. So you can see this. This is the aorta. Discuss that aorta should always, in the normal patient, aorta should always go to the pulmonary artery. But in this, you can see this aorta is anterior. The transmission of grade. And if I scroll it down, you can see this pulmonary valve. This pulmonary valve is thickened. To see on me image. Yeah. So you can, this is the pulmonary valve. You can see this pulmonary valve leaflets. This valve leaflets looks like a dome shaped. You can see leaflet. So this, though measure the pressure gradient directly, but if you
Sir, your audio,
valve,
sir, sorry to interrupt,
pulmonary.
sir. Your audio, people are requesting your audio is not audible. Means it is your network issue is there. Means internet is going off and on. Switch, sir, if your video is on, switch off your video so you will save some bandwidth. Because people are saying there's connection problem at you, means internet issue at your end.
It's okay now. Are you able to hear?
Better, sir.
Better, okay. So what I'm saying, I'm showing you is the status of main pulmonary artery. So you can see this is the main pulmonary artery here, and this is the pulmonary valve. The pulmonary valve here looks like a dome-shaped pulmonary valve, and the pulmonary valve leaflets appear thickened. Though CT cannot measure the pressure gradient directly, but if you see a presence of thickened and the dome-shaped pulmonary, especially the dome-shaped pulmonary valve, it's suggestive of pulmonary stenosis at the level of valve. The infundibulum is normal. There is no infundibular stenosis. The diameter of like in this image, you can see the pulmonary arteries are confluent. Right pulmonary artery, left pulmonary artery, they are confluent. Main pulmonary artery is also normal. So let me come back to the case. So we have determined three things. The atrial situs is normal. Atrioventricular concordance is also established, but there are double inlet left ventricle and detransposition of great vessels and double SBC. So this is a little complex case. So I have summarized the findings. I think, do we have time for another case or shall I stop it here?
Dr. Neeraj, I think you can present one more case.
Yeah.
Now voice is a bit better.
Okay. So let's see the another case. Okay. So again, this is a young child who came for the evaluation of congenital heart disease. So in the first step, we see the position of abdominal organs.
Sir,
So you can see.
share your slide. We cannot see the slide.
Okay, okay. Okay. Now it's visible.
Yeah.
So now this is a young child. So first step, we see the position of abdominal organs. So you can see the right lobe is on the right side, stomach and the spleen on the left side. So normal abdominal situs. Now we see the position of and the morphology of the bronchi. So if I scroll it like here. So you can see this, the left bronchus, the left non-bronchus shows the distal takeoff of left upper bronchus, and it is situated inferior to the left pulmonary artery. So it's a epiatal bronchus. Whereas the bronchus on the right side, here you can see it has got early takeoff. So it looks like a morphological right bronchus. So we can safely presume here that right atria must be situated on the right side and the left atria on the left side. But anyway, we'll confirm on the axial images. So you can see this is the right atrial appendage. It's broad, it's trapezoidal in shape, and it has got broad communication with the right atrium. So if I scroll it down, I'm going to show you the left atrial appendage as well. You can see here, this left atrial appendage is narrow, tubular, and it has got narrow connection with this rest of the left ventricle. So this looks like a morphological left ventricle, and this looks like a morphological left atrium, and this looks like a morphological right atrium. So there is a normal atrial situs. So in the next step, we are going to see the venous connection. So you can see this is the superior vena cava filled with the contrast, and this superior vena cava is joining the morphological right atrium. And if I scroll it down, you can see this inferior vena cava here. This inferior vena cava is joining the morphological right atrium. So the rule of veno-atrial concordance is also followed in this case. Now we see the venous connection to the left atrium. So you can see here the pulmonary veins from the right side and the pulmonary veins from the left side all are joining into this chamber, which we have established as a morphological left atrium. So the venous connection to the left-sided chamber is also normal. Next step is to see the presence or absence of septal defect, though the image quality is not very good, but you can see the interarterial septum appear to be intact. There is no mixing of the contrast, no jet of contrast is seen across the interarterial septum. Now we are going to see the atrioventricular valve. So the atrioventricular valves also appear to be normal. Now we see try to identify the ventricles. So you can see this particular chamber, it has got thick trabeculations and the moderator band, which is extending from the interventricular septum to the cardiac apex. So this looks like a morphological right ventricle, and this looks like on this chamber you can see the septal surface is smooth. So this looks like a morphological left ventricle. So you can see this is a normal D-loop arrangement where the right ventricle is situated right of the left ventricle. This is the left ventricle. Now we have seen the ventricles. Next step is to see the great vessels. So you can see, like we have already established and we have already learned the rule that the aorta has to be right of the pulmonary artery. But in this case, you can see the aorta is anterior and the left of the pulmonary artery. Where is the pulmonary artery? Let's see. So you cannot see the main pulmonary artery. You see the right pulmonary artery, you see the left pulmonary artery, but the main pulmonary artery is absent. In place, you can see this thin streak of contrast or a thin tubular structure, which may be atretic main pulmonary artery. So if we expect this is the location of the main pulmonary artery, the aorta is definitely anterior to the main pulmonary artery. So this is a detransposition. This is the vessels. This kind of vessel arrangement seen in detransposition of great vessels. let's see from which chamber which vessels is arising. So if I trace it down, I can see this aorta. This is the aorta, and this aorta is appear to be coming out from this chamber. So we have established this. This is a morphological right ventricle by presence of moderator band. Here is a moderator band. So you can see there is a ventriculo-arterial discordance. The aorta is coming out from morphological right ventricle, and we cannot see the origin of pulmonary artery because the main pulmonary artery is absent, and the right and left pulmonary artery also non-confluent. There is no junction between the right and left pulmonary artery. If I go down, so next step comes is if the main pulmonary artery is hypoplastic or atretic, so where is the blood from? Which source the blood is coming into the pulmonary artery? So there are it either coming from the major aortopulmonary collaterals or it coming from the patent ductus arteriosus. So you can see this is the descending thoracic aorta, and this is the channel which coming from the descending thoracic aorta and joining the pulmonary artery. You can see this is joining the right pulmonary artery and supplying the right pulmonary artery. So there is a presence of patent ductus arteriosus in this case. So let's see the chest also. So the lung appear to be normal, no collapse, no consolidation is seen. Now time to see the abdominal organs for any abnormality. The abdominal organs also appear to be normal. So to summarize this case is suggestive of situs solitus, normal atrioventricular concordance, which means the right atrium is joining the morphological right ventricle and the left atrium is joining the morphological left ventricle. But there is a ventriculo-arterial discordance because the pulmonary arteries appear to be arising from morphological right ventricle, and we cannot determine the origin of pulmonary artery because it's atretic. So in this case, there is a presence of DTG, detransposition in blood vessels. One more point here I would like to discuss is the concept of double outlet right ventricle. So we can see that this is the interventricular septum, and this part of the interventricular septum is missing. So there is a big subaortic ventricular septal defect is present, and this chamber, which has got coast trabeculation, appear like a morphological right ventricle. So you can see this aorta. If I draw a line parallel to this interventricular septum, you can see this more than 50% of the aorta is receiving blood supply from the morphological right ventricle, and only a small part of the aorta joins the morphological left ventricle. So this is a double outlet right ventricle kind of arrangement. And in this image, you can also see this patent ductus arteriosus coming out of descending thoracic aorta and joining the pulmonary artery. So to summarize this case, this is the situs solitus atrioventricular concordant, but the ventriculo-arterial discordance. The important point here is the non-confluent pulmonary artery, pulmonary atresia, and detransposition of blood vessels. So coming back to the actual presentation.
Dr. Anish?
Yeah, just let me know.
Yeah.
So To summarize the talk, in the first step, we determine the visceral situs, thoracoabdominal situs, and the next step, we determine the atrial situs. We have to look for the presence or absence of septal defect, the venous connection, presence or absence of membrane. Next step, we determine the atrioventricular relation, where they are concordant or discordant. What is the status of atrioventricular valve? We have to determine the ventricular looping, whether it's a D loop arrangement or the L loop arrangement. We have to see the position, the relationship of great vessels. It's the levotransposition of great vessels or the dextrotransposition of great vessels. We have to give the diameter of the pulmonary artery and the aorta. And in the last, we have to look at the status of the lung and the abdominal organs. Thank you.
Hello.
Yeah.
Audible, right? Yeah.
Yeah.
To all the viewers, if you have any questions to Dr. Neeraj, you can post it in the chat box.
So I'm just seeing the questions. Dr. Rajesh wants me to explain the DORV again. And the second case, DORV is there. Yes, then the second case, there is DORV. So somebody like me to describe the DORV again. Okay.
Yeah.
So what happens? So here is our rule of DORV. If one great artery and more than half of the other great artery originate from morphological right ventricle, then we classified it as a case of double outlet right ventricle. Like in this case, you can see this is the interventricular septum, which is dividing the morphological left ventricle from the morphological right ventricle, and the aorta completely arising from morphological left ventricle. But in this case of DORV, you can see interventricular septum is there. The part of the interventricular septum is missing. So there is subaortic ventricular septal defect is there. The septal surface on this side, which looks like a morphological left ventricle, is smooth. And the surface on this side appear to be attached by the papillary muscles. So this looks like a morphological right ventricle. If I draw a line from this interventricular septum, and you can see the more than 50% of the aorta is arising from the receiving the blood supply or the arising from morphological right ventricle. So it is suggesting of double outlet right ventricle. Again, in this case, you can see if I draw a line from interventricular septum, you can see this aorta is arising from morphological right ventricle, which can be characterized by presence of thick trabeculation. One more point, though it's not a diagnostic criteria, you can see in a normal patient, there is a fibrous continuity between the aortic valve and the mitral wall, and this fibrous continuity is lost in cases of double outlet right ventricle. This is the aortic valve, this is the mitral valve, and there is no fibrous continuity here. So I hope this answers your question. Dr. Ishita wants me to explain the D loop again. Okay. Okay. So you can see in a normal patient, this is a right ventricle, which can be identified by presence of moderator vein. So this the looping can be determined by several ways. So one way to determine the looping is to determine the position of the chambers. So you can see this right ventricle is situated. This is the left ventricle. So right ventricle is situated right of the left ventricle. So this kind of arrangement is seen in L loop. Well, in this image, you can see this chamber, which looks like a morphological right ventricle, can be identified presence of moderator band. So this morphological right ventricle is situated left to the, this is the left ventricle, left to the left ventricle. So this is a L loop kind of arrangement. Another way to determine the loop is to see the position of the great vessels. If you find the aorta to the right of the pulmonary artery, it suggests D loop arrangement. And if you find aorta left of the pulmonary artery, it suggests L loop arrangement or the L loop kind of ventricular looping. I can't see any other question. So, anyone have any other question?
Dr. Neeraj, one like not exactly related to the topic, like but related. I have a doubt, like what is the advantage of cardiac CT over cardiac MRI in congenital malformations?
Usually, even if you go for the pre-operative analysis of congenital heart disease, they won't need CT at all. Everything can be evaluated with the help of echocardiography. So the majority of the patient who comes to us for a very specific clinical indication, like they wanted to know what is the status of pulmonary artery, whether the pulmonary artery is small in size, whether they are normal in size, whether they are confluent, is it absence of pulmonary stenosis. So in these cases, definitely the CT angiography is better, because the cardiac, first of all, the cardiac angiography requires a lot of preparation. The scanning time is too much. You need to sedate the child for a longer period of time. And if you wanted just a small information about the pulmonary artery, the CT angiography suffice. Now the role of cardiac MRI. The role of cardiac MRI is, predominant role is in the post-operative evaluation of the congenital heart disease. For example, if the patient was operated for tetralogy of Fallot and they wanted to see the gradient across the pulmonary valve, or the size or the volume of the volume or the size of the right ventricle, and they want to follow what is happening to the right ventricle, it has become dilated or not. So the cardiac MRI more role is in the case of post-operative evaluation. CT is more helpful in pre-operative evaluation.
Okay, so basically in pre-operative evaluation where ECG has some limitations, right?
Echocardiography.
Yeah, sorry, echocardiography. Right. Okay, any more questions from audience? No, I'm not seeing any questions. So I think it is time for us to wind up. Even though, as we know, that cardiac imaging, especially cardiac CT, is not commonly done, and it may be tough for most of us, especially for residents, because it's rarely done. But still, with your presentation, you have simplified it so that most of us can understand. And it was with all the related cases and like in the slide, and also other cases with the systematic approach you have explained. It was a nice presentation, even though there were some technical issues. We could not hear the first case very nice, but second case we could hear properly. So anyway, thank you, Dr. Neeraj, for the presentation, for the time, for the effort you have spent for IRIA and your association.
Anybody wants to, if they were not able to see the first case, anybody would like to see the first case, I can show them to again.
Yeah, if you can briefly show as a conclusion.
Only if the residents are interested, I can show the second case again.
Any residents?
Yeah, they're saying yes, sir. We have got.
Yeah.
Okay. So screen is correctly visible?
Yes.
Dr. Anish, okay.
Yes.
So this is a young lady. So first step, we see the position of abdominal organs. So you can see the largest lobe of the liver is on the right side, stomach and spleen on the left side. So normal abdominal situs. In the next step, we see the bronchial anatomy. Okay. So you can see this. This looks like a right bronchus because it shows the early origin of the early takeoff of the right upper lobe bronchus, and this looks like a morphological left bronchus because it has got distal origin of left upper lobe bronchus. In addition, you can see this left bronchus is situated distal or the cranial or the inferior to the left pulmonary artery. So this is the epiarterial bronchus and this is the hyparterial bronchus. Now comes to the axial image. So we have determined this bronchial situs. So we can safely presume that the right atrium must be on the right side, left atrium on the left side. Anyway, we see the internal characteristic of the atrial chambers. So you can see this chamber. This chamber looks like a morphological right atrium because the right atrial appendage, it's a broad. It has got broad communication with the right atrium, and you must have remembered the rule of veno-atrial concordance, which is the any chamber where the SBC or IVC opens or the coronary sinus opens is usually a right ventricle. So you can see this is the inferior vena cava, and this inferior vena cava is opening into this big chamber. So this chamber has to be the right atrium. So we established this is the right atrium. Now we need to see the another chamber. You can see this is the another chamber, and this chamber looks like morphological left atrium, which we can identify by morphology of left atrial appendage. So this left atrial appendage, it's a conical, and it has got relatively narrow communication with the left atrium, and so it looks like a morphological left atrium. So we have seen the venous connection to the heart on the right side. Let's see the venous connection of the left atrium. You can see the pulmonary veins from the left side, pulmonary veins from the right side. All are joining this chamber, which is the left atrium. So there is a normal venous connection to the right as well as left atrium. Next step is to see the atrioventricular valve. So you can see, before coming to the atrioventricular valve, I would like to discuss the ventricular morphology because of one particular reason. I'll discuss it later on. So you can see there are two chambers. One chamber here is a small chamber. Another chamber is a big chamber. So if I scroll it down, you can see this is the interventricular septum. So septal surface towards the small chamber is not smooth with attachment of trabeculation, maybe a moderator band. So this small chamber looks like a morphological right ventricle, and septal surface toward this side is smooth. So this looks like a morphological left ventricle. So the ventricular arrangement is normal. The right ventricle is on the right side, left ventricle is on the left side. So coming back to the atrioventricular valve, you can see there is no connection between the right atrium and the right ventricle. Instead, you can see there is a fibrofatty ridge is interposed between in the right atrioventricular groove. So there is no communication between the right atrium and the right ventricle. So where is this right ventricle opening then? So if I scroll it down, you can see this right atrium is connected to the morphological left ventricle. So if right atrium is connected to the morphological left ventricle, where is the left atrium then? So if I scroll it up, you can see this left atrium is also connected to the morphological left ventricle. So what we are seeing is both right as well as left atrium is connected to the morphological left ventricle. So it is suggestive of double inlet left ventricle. So now we have determined the atrioventricular relation. Next step is to see the position of great vessels. So in this image, you can see the aorta. The aorta is abnormally positioned. It is right or anterior to the pulmonary artery. So this kind of arrangement is, this kind of arrangement is seen in detransposition of great vessels. So you can see we have discussed and we have learned that the aorta has to be posterior structure, but in this case, you can see the aorta is anterior and right, suggestive of detransposition of great vessels. So now we have seen the relations of the vessel. Next step is to see the presence or absence of any stenotic lesion. So for that, I'll make it a multiplanar reconstruction image. So here you can see, here. So you can see, so this is the main pulmonary artery. This is the aorta, and you can see this aortic valve here. This aortic valve is thickened and it's a dome-shaped aortic valve. So there are various kinds of pulmonary stenosis, and And the dome-shaped pulmonary valve is the most common morphology seen in cases of pulmonary stenosis. So though CT cannot measure the pressure gradient directly, but if you see a presence of or thickening, presence of thickened and dome-shaped pulmonary valve, always think of pulmonary stenosis. So there is evidence of pulmonary stenosis. But apart from this pulmonary stenosis, the pulmonary infundibulum, the region which is located just underneath the pulmonary valve is normal. The diameter of, here you can see the diameter of main pulmonary artery, right pulmonary artery, left pulmonary artery is also normal. So we have seen this, there is only one thickening of pulmonary valvular leaflet is present. So there is presence of pulmonary stenosis. Aorta is normal. Now, last step is to see the lung. You can see lung appears normal. There is no collapse consolidation, no the vascular abnormalities.
I think Dr. Neeraj got disconnected. Hope he will join back again. Oh, he's there. Dr. Neeraj?
Dr. Neeraj got disconnected.
Yes. So he'll join back again.
Sorry for the loss of connection. So
Okay.
again, to summarize the findings, that the abdominal situs is normal, atrial situs is normal. You can see the ventricular-arterial concordance is normal, but the right atrium is not connected to the right ventricle. Instead, both right and as well as left atria is connected to the morphological left ventricle, suggestive of double inlet left ventricle, and there is a detransposition of great vessels and pulmonary stenosis. So these are the findings in this case.
Okay.
So
yeah. You're done, right, Dr. Neeraj?
yeah, I'm done now.
Okay. Thank you, Dr. Neeraj, again.
Though I think
for all.
just one more. Though it may seem little complicated, but if we go step by step and try to see the normal structure first, then it may be easy.
Yeah. Like any minimum technical machine specification, like how much slice CT is needed or cardiac CT?
At least 64. At least 64.
Okay. With beta blocker cardiac regulation also.
Because what happened is no, we cannot give beta blocker to the kids. We cannot reduce the heart rate.
Okay.
So like certain machines, like the Philips machine we have got, has a limitation that it cannot obtain the ECG gated scan until unless the heart rate is less than 140. So at least you need, if the heart rate is around 100, it's very good.
Okay.
But if it is more than like 130, 140, then you may not get very good quality images.
Okay. Okay, Gomati ma'am.
Yeah. There's a wonderful presentation, Dr. Neeraj. The cases were very good, except for the net issues, but last time which you showed was very good. So thank you so much, Dr. Neeraj.
Thank you, ma'am.
Okay, now I want
Dr. Venu?
Nothing, madam. It was just a just message that is just cute and simple. And I think those who attended the webinar know they have understood. And the fundamentals have been paved in. And then if they start reading on that, and if they start to go systematically, then one will understand if some deviation is there. So that's very important. And it is just like the neurological pathway, starting from thalamus, like the corticospinal tract and all this, say from superior vena cava, inferior vena cava to right atrium, like that. So it's a wonderful presentation. Thank you, Dr. Neeraj.
Thank you, sir. Thank you, sir.
Thank you, Dr. Neeraj, once again.
Thank you, Dr. Anish.
Our IR President, Dr. Where and off screen for all these of IRA. Thank Gomati ma'am join today's session. Now I would thank Academic Chair IRIA Kerala, sir. Thank you, sir. I also want to thank academic coordinator, state coordinator, Dr. Ramesh and I, and IRIA State Secretary, sir. Under his guidance, we are activities on years we are improving, hopefully. So first I want to thank a great team giving and arranging for today's session. Finally, I want to thank all the viewers of involved and for all the people, all the consultants. I think all of us have new knowledge, and okay, I think that is today's session. The week will be the cardiac session on masses, MRI masses. This fifth PG presentation on cardiac mass, and Saturday the 12th faculty talk. So we'll be sharing the details shortly. Just all the viewers to and also share. I think conclude.
We can end the session.
Yeah.
Yeah. Thank you, doctors. I think we are very happy to be part of this. Look forward for another edition of IRIA Kerala. And we will be bringing some new innovations, which we are already preparing for the, for the knowledge of all of you radiologists. Thank you once again. Have a nice evening and a great week.
Okay. Thank you.
Thank you.